Hello, everyone, and a warm welcome to our Better Data, Better Outcomes event. For those of you who don't know me, I'm Clara McKay, CEO of the World Ovarian Cancer Coalition. So today's event is part of our series that focuses on the 6 goals set out in our Global Ovarian Cancer Charter. Today, we're looking at data improvement and why we need to prioritize better data to improve ovarian cancer survival and quality of life. And that's for all women, no matter where they live, in all countries and across all communities. But firstly, I'd like to take this moment to formally thank our industry partners who are sponsoring this series of events. As always, we are enormously grateful for your support. So now to our live panel discussion, which will tackle 2 key and very important topics, which are diversity in relation to those who participate in clinical trials and why this is such an increasingly pressing issue for ovarian cancer. And secondly, geographical diversity in trials and research. And again, why is it so important that we ensure that trials are run more globally and made available to local populations? Today, we are joined by an outstanding panel that is global, a panel with great expertise and insight. So we're just delighted that you all could make time to join us today. So today we have with us Professor Sudha Sundar, who is consultant oncologist and chair of the British Gynecologic Cancer Society. Tomi Akinamaju, an epidemiologist and associate professor at Duke University. Tomi is currently working on an NCI study on racial disparities in ovarian cancer in the US. Rose Anorlu, professor of obstetrics and gynecology and president-elect of the African Organization for Research and Training in Cancer. Runsi Chedabi, founder and executive director of Project Pinkblue. And if you haven't heard of them, Project Pinkblue is a dynamic, not-for-profit based in Africa, engaged in all aspects of cancer, including awareness, cancer screening, training, support for patients, and cancer research. And finally, but not least, we have Mary McCormick, who's consultant clinical oncologist and past chair of the Cervical Cancer Research Network. So this is a network that is dedicated to increasing access to clinical trials in low and middle income countries. So welcome everyone, we're delighted you can join us. Sudha, we're gonna start with you. You're a clinician and researcher who works in Birmingham, a highly ethnically and culturally diverse city in the north of England. You also work and research in India. Now, I know you have strong views about the lack of diversity in research and clinical trials. And indeed, I also know that you've dedicated much of your own career to trying to address this problem. Now, you said something to us in 2018 in an interview you did for the Every Woman study, which I think may sum up your position, which was, now I'm quoting you, what we do know is that many of these women from the Asian and Black population tend to get ovarian cancer a whole decade earlier or younger, but nobody understands this or what happens to these women because the literature is dominated by Caucasian people. I'm not sure we have equity of access or equity of knowledge, certainly. So I think that's really striking. So basically what you're saying is there are large pockets of populations of women in the UK and globally for which we have little or no insight about the specific factors related to their ovarian cancer. So I want to ask you, Sudha, what have you learned from your efforts to change this? And can you tell me why it is so important and in very practical terms, so important for women in, say, Birmingham in terms of increasing this diversity and understanding of the disease?
Thank you. Thank you for inviting me to be present in this panel. And I'm somewhat humbled to be part of this panel with very, very eminent speakers. So I think this is an incredibly important topic, and I'm delighted to see that the World Ovarian Cancer Coalition is raising this and has featured this this afternoon. And it's a really far change from this topic, not even featuring the subconscious of people, I think. So if we look at ovarian cancer, and if we look at something as common and as fundamental as BRCA prevalence, so the Angelina Jolie gene, the proportion of women who have the mutations or changes in the BRCA gene, and we know this causes anywhere between 10 to 15% of women with the most common variety of ovarian cancer. We don't actually know what proportion of Asian women have this BRCA gene. We do know that we looked at the literature a couple of years ago, looking to see what robust data we had with new technology, which is next generation sequencing technology. And it was very hard for us to find out what proportion of women we could actually quote that actually had this gene. And that's because we only had 3,000 patients who'd been studied in the whole of literature. There's another 1,000 and odd been added to. But the trouble is that with all of this data, it's quite hard to work out what the actual proportion is because of the way the data is collected. It comes from a very skewed population. Without even understanding the sort of basics of why we have ovarian cancer, why it might be happening a bit earlier, is that because we have a younger patient cohort in the African continent and the Asian subcontinent? Is that just an epidemiological shift, or is that a genuine biological thing? We don't know, and we haven't been able to explore this. Certainly sitting in Birmingham, which is very, very multicultural. And in my own hospital, City and Sandwell Hospital, there are more non-white babies born than white babies born. It becomes quite a challenge because we haven't got the kind of trials data that can reflect the population that we serve. We don't fully understand the cultural reasons why people take testing up. We don't have the tools, and it's very amusing that for a population, for a hospital that has a very high Punjabi population, I had to get the Punjabi BRCA testing leaflet done in Punjab in India because we didn't have a leaflet. So this is the sort of thing that sometimes we need to really reflect, are we serving the population that we are treating? So the things that we are doing at Birmingham are that we are, as of January 2021, we will be training up genetic liaison workers, community workers who can be community advocates, who can go out to the mosques and the temples and the gurdwaras and the churches to explain a little bit more about cancer and why it's called, and cancer genetics, and try and increase the understanding of people so that they will take up testing a little bit easier. We're also trying to develop communication materials that will be more useful so that we can reach our populations more effectively. And of course, we're doing some work in India in matching populations so that we can understand whether there are differences between Indian populations in Birmingham and Indian populations in India. So these are the things that we are doing, but there's a whole lot more to be done and across globally to increase the knowledge that we have about ovarian cancer in women in diverse populations, and also to increase the equity of access, I think.
Thank you. I think that's so powerful. Just that whole thing that, you know, leaflets about testing are presumably just not in languages that reflect the populations that we're serving. And it's such a basic thing. We do often think about some of the bigger barriers in terms of access, but, you know, that feels to me like a fairly significant, but not insurmountable challenge. And yet we're still at that point. And you talk about the BRCA testing, and I really kind of want to come back to that whole point, because I think we have a sense, I believe, that now we really do need to kind of up our game, I guess, in terms of access, and in ovarian cancer world in particular. Are we at a position in terms of ovarian cancer treatments where we just really need to ensure that everyone has access to these tests and to those treatments, and our understanding of how they work in different populations?
And I think the other important thing with identifying these families is that there's also a huge scope for prevention. So
yes,
that, I think, is the massive, and we don't fully understand the cultural. Currently, our counseling for BRCA testing is pretty monotone. So it assumes that everybody comes from the same background, whereas those of us who are from ethnic minorities, we understand that there are cultural overlays to this question. So these are the things that I think are unexplored and need to, and certainly working in the UK, I feel very strongly that otherwise we will just entrench inequality because there'll be a group of population that will progress very quickly and the other will have a knowledge gap because the knowledge gap isn't acknowledged.
Correct. And I think that's a really nice point to turn to Tomi now to bring you into this conversation. So if you would turn your video and your audio on, so we'll have a chat with you. Thank you again so much, Sudha. And we'll come back to that. I think these themes will come out through all of these conversations. But Tomi, you're an epidemiologist. So that means you're asking questions from a population perspective. And currently you're working on a National Cancer Institute funded study looking at ovarian cancer and racial disparities in access. And we spoke to you earlier this week and we were discussing why your research is so important. And you pointed something out that I think is really important to start with, which was over the past decade, there have been advances in ovarian cancer, but not all racial and ethnic groups have benefited equally. And that sort of really picks up on what Sudha was just saying. But you said something which really stuck with me. And it was something like, when things are bad, it's mostly bad for everyone. But when treatments get better, the disparities widen. So I wonder if you could first start with that and just share a little of the background about what we do know about racial disparities in ovarian cancer outcomes in the US between different populations. So if you could start with that, thank you.
Sure, and thanks for inviting me to be on the panel. It's very, I'm highly honored to be here. So yeah, like you said, our motivating example for our current project on ovarian cancer disparities started by looking at cancer registry data in the US and comparing ovarian cancer, 5-year survival rates among white women and African-American women. We were interested in seeing how things have progressed since the 1970s up until the latest year of data that we had at that time, which was 2009. And what we thought was, given the recent the improvements in treatment strategies that started in the 80s, we were expecting to see a trend where all racial groups kind of experienced increased survival as a result of those improved treatment strategies. We did expect to see some disparity, that maybe certain groups would do better than others, but we expected to see a general trend where everyone was benefiting from the improvements. But what we found to our surprise was, comparing 5-year survival rates between 1975 and 2009, when we look overall across the whole population, there was an improvement of about 38% in 5-year survival rates, which is really good news. It went from about 34% to 47% across that time period. But when we stratified by race, so when we separated out white patients and Black patients, we found that essentially all of that improvement were restricted to white women. Their 5-year survival increased from 32% to about 47%. But for Black women, we found that their survival rates actually declined by about 27% over that time period. So, in contrast to what we were expecting to see some improvement in all groups, but maybe greater in one, we found this inverse trend that, was quite baffling at that time. And, but when we went back to look in the literature to look at, theories and frameworks around treatment and survival for cancer in particular, we found that this has actually been described before. And this is a general trend that's consistent across many cancers. So when you look at cancers that are highly amenable, so highly treatable and effective treatment strategies exist, that's where we see the biggest disparities. Those are highly amenable cancers. We know what the treatment strategies are and the treatment works generally. That's where we see the biggest cancers. For cancers that are not amenable, so things like pancreatic cancer, that we don't yet have effective treatment strategies, we don't really see disparities because survival is low across the board, which is a challenge in terms of our public health strategies when we know what works. And we're seeing such stark differences by race, really poses a challenge for us, which is what led us to our grant to focus on access to care. There must be a gap in accessing those new effective treatments. It may be related to cost, it may be related to distance or availability or geographic factors, but those are the issues that we need to address in order to make sure that treatment is equitable across all racial groups.
Indeed. So I just want to repeat that because I think that's such a shocking statistic, that 5-year survival rates, we're talking about the US, that overall in the white population, there was an improvement in survival of, I think you said about 30%. In the Black population or the non-white population, there was a decrease in survival by about 27%. So that's actually a really shocking kind of, you know, another, we call them fall off your seat moments kind of here at the World Ovarian Cancer Coalition. So picking up from there then, so tell us a bit about the actual research that you're doing. And I know you're sort of looking much more deeply at the factors that may impact on the barriers to access for women from racial and ethnic groups.
Yeah, so as we continue to do our research to try to understand, you know, the trend, that statistics that you mentioned, trying to think about, you know, where we can intervene and how we can address that issue. We began to focus more specifically, again, on access to treatment. And again, using cancer registry data, and to your point earlier about the importance of really collecting good standardized data across all settings, we're able to make use of the, you know, the excellent work of the ASEA cancer registries that have been in existence and funded by the government, you know, for many decades. And that provided us an opportunity to look at a large number of women of different racial backgrounds. And we were interested in the characteristics of the neighborhoods that the women lived in terms of healthcare access. So we defined healthcare access, in this case, based on availability. So do you live in an area where there are healthcare resources? So number of hospitals, number of oncology hospitals, gynecologic oncologists. And then using our registry data, we compared Black and white women, cancer patients. And to our surprise, what we found was that Black women were more likely to live in neighborhoods that had more healthcare resources. So they had more hospitals, more gynecologic oncologists available, more OBGYN relative to their population size compared to white women. Part of that is driven by rural-urban differences. So Black women are more likely to live in urban areas. But when we look on the surface at availability of resources, Black women do tend to live in areas that have more healthcare resources. When we look at among those same patients, receipt of surgery, we find that Black women are less likely to receive surgery for their cancer. So again, there's a, you know, really stark disconnect. You know, survival rates are declining, but women are living in areas where there are resources, but they're not really accessing those resources. They're not utilizing those resources to get treatment. Which led to our next question, which is, okay, if it's not availability of resources, then what else might contribute to this disparity? And so again, we took a step back, went to look in the literature, found that back in the 70s, there had been a theoretical paper by an economist, health economists, that proposed that healthcare access is not just about insurance or co-pays. You know, the financial aspect is one piece of it, but there are 4 other pieces. And another one is the availability, which I just described. So do you live in an area where there are healthcare resources? Other than that, there are other dimensions as well. There's one related to acceptability. This is the patient-provider interaction and the patient's experience access in the healthcare system. There are things about accommodation. So is the healthcare resource that's available to you at a time and place that's convenient for you to access? And then there's the accessibility, which is distance. You know, how many buses or trains, or how long do you have to drive to get there? What we found as part of our grants that's funded by the NIH, doing focus groups among ovarian cancer survivors, is that there are challenges related to affordability. There are cost challenges. There are issues related to insurance that seems to be disproportionately affecting minority populations. But again, there are not major issues with availability. They do live in areas that have healthcare resources. But a really salient challenge that a lot of minority patients face is this acceptability dimension, which is a lot of patients do not feel that they can fully trust their healthcare providers. They don't report that they feel a sense of empathy a lot of times from their provider. They have issues regarding communication, like the tone in which they are spoken to within the healthcare system. So all of that, taken together, just leads to a sense of mistrust and a sense of, not feeling cared for, not feeling really respected as a patient. And all of that taken together may partially explain why, despite higher availability, minority patients are hesitant to access healthcare. And this translates to not only utilization of care for their treatment, it translates to participation in clinical trials. If you're having a conversation with someone and you're not sure that they have your best interest at heart, when they recommend to you to participate in a clinical trial, chances are you might be a little bit hesitant to do that.
Thank you. That's really important. And that kind of stands out as a key issue about trust. And I think it's something that came kind of up when Sudha was speaking earlier as well. And I think, there's definitely a direct kind of crossover into why people may not be willing to participate or feel that research and clinical trials is actually about them as well. Rose, if we could kind of bring you in now. So we've heard from a UK and a global and a USA perspective, and your background is you have a long-standing career as a clinician, researcher, and advocate in gynecological cancers in Nigeria, including many years involvement with the African Organization for Research and Training in Cancer. I wonder if you could share your perspective from someone who is on the ground in Nigeria. What are the challenges for bringing cancer research to Nigeria for Nigerian patients? And I think because you do have a very long and distinguished career, perhaps you could tell us the progress or lack of, I guess, that you have seen in your work.
Like you said, I've had a long career in oncology. Now, ovarian cancer, what I've noticed now, and from my experience, though it's not, we haven't published that much papers, that in recent times, we see more and more of ovarian cancers. And in my hospital, the Lagos University Teaching Hospital, in my unit, that the gynae oncology unit, we see about 2 to 3 new cases of ovarian cancer every week. And it's also now, they come in very advanced stage. And they come, ovarian cancer has now become the common cause of death in the gynecological wards. I did a paper about 10 years ago, and it was more of cervical cancer. But now it's become ovarian cancer. And why is this so? Why these trends? We try to find out why we have that trend. Is it that there's more awareness of cancer in general? Because before, very few people knew about the cancer. I remember in 1990, in about year 2000, I did a short study among women attending mother and child immunization clinic for mother and child clinics. And I interviewed 500 women, and out of them, none of them had heard about cervical cancer, not to talk about ovarian cancer. They knew about breast cancer. But I'm sure now, if one goes there and do another survey, you find that they are getting more and more aware of cancer. And some of them will tell you about cervical cancer. And thanks to the NGOs, they've been doing wonderful work across Nigeria, trying to raise awareness of cancers in general. But I also noticed when we look at literature about the epidemiology of ovarian cancer, we find that it's a little bit different in our setting, because they tell you in the textbooks or in literature that it's women that low parity women, but here we just have women that para 10 and para 6 they have ovarian cancer. So you start wondering, is the biology and the genetics of ovarian cancer in our set, is it the same as elsewhere? And there's been instances, again, because of lack of data and, funds for research, there's been instances, I think I've seen about 10 of such cases of a woman, as you are treating her for ovarian cancer, the next moment she tells you that she's felt a lump in the breast. And then when you send her to they go and do a biopsy and they have breast cancer. Nobody has looked at all that. So I think there's a lot of work and research to be done about ovarian cancer.
We are losing you a little bit there.
And like one of the speakers said, one of these earlier speakers said something about doing some more studies, like doing the BRCA mutation testing. I mean, that one is like almost impossible now in this part in my country, because it's very, very expensive. And even those that are on treatment, they don't have the funds to pay for that, to pay for their treatment, because here it's more of out-of-pocket payment. And, many patients can't even afford the chemotherapy that you give to them, not to talk about asking them to do BRCA1 and 2 testing. So again, we have gaps there, which, I'm sure nobody knows, the percentage of women with ovarian cancer in Nigeria that have, mutation on this gene, this anti-cancer genes. Yeah. So we have a lot, to do. We need to do the epidemiology of, ovarian cancer, do a re-epidemiology of ovarian cancer in my country. I mean, I've seen studies that just do, not the detailed, when you say epidemiology, I'm yet to see a paper on that. So we have a lot, and I'm glad that your organization is taking taking interest in ovarian cancer, an area that we don't talk much about. Like this morning, it was all cervical cancer. Yesterday was the inauguration of it's 90. I mean, the elimination of cervical cancer. But there's a lot of excitement. But how many NGOs are really into ovarian cancer?
Sure.
Maybe we just have very few in ovarian cancer. So it's an area, and it's killing a lot of women. I mean, those that we see are those that were able to bring themselves to the hospital, to the teaching hospitals. We don't know how many women that live in the rural area where almost 60% of the population live, that have ovarian cancer, that die of ovarian cancer, because we don't have the personnel, the doctors or the oncologists there to start making diagnoses. So it's a huge problem, unfortunately.
I think it is, yes, and I think you've hit on some of the key things about, but it's interesting how you talk about how people are now aware of cervical cancer, and then, breast cervical cancer. And so there's clearly an awareness element to it. And, but, fundamentally, without the data to understand, the epidemiology data to understand what is happening and is it different, it's very hard to kind of have a strategy to tackle. Runsi, if I could bring you in here now from a patient advocacy organization, and I have to say an organization that is truly fighting with and behalf of cancer patients on all fronts. Can you tell us about your view? Again, I know you speak very eloquently about the barriers to research and trials in Africa, and how we might tackle some of those. What's your perspective from a patient advocacy organization?
Okay, yeah, thank you very much, Claire. I really appreciate this great opportunity. But just to ensure that I don't get caught off by data or internet, I will turn off my video, but at least you have opportunity to see my face.
It's lovely to see you.
So first of all, I just wanted to say that I'm really honored to be like the only guy, the only man among the women, which is really, really interesting. Thank you so much. So honored. You see, cancer in Nigeria, it's usually in Nigeria and in many parts of Africa, it's usually not discussed from the perspective of a patient. and which is what we are trying to change. Many people haven't really have the view that cancer is about that woman that is dying, or when you Google about cancer in Africa, the pictures you see are pictures of people who are dying, pictures of people who are like lying down, not having access to. So what Project Pinkblue have been trying to do is to put a face to cancer in Nigeria and in Africa. And that is why we started the first breast cancer support group in Abuja. Because I realized I myself from Project Pinkblue have been creating a lot of awareness, creating a lot of, doing a lot of advocacy to bring people to really understand the need. But I think it's time I lose my job. I need to lose my job and bring the patient in the forefront. You see, because there's a need to change the way the global community see cancer and other illnesses in Africa. It's not all about death. There are still so many resilient people who are doing amazing work and really want to be supported. For instance, in the area of ovarian cancer, in 2018, it was really stated that about 2,792 women actually died of ovarian, women actually were diagnosed with ovarian cancer. And out of that 2,792, about 2,063 women actually died of this disease. So ovarian cancer, as it is in Nigeria, is number 8 in Nigeria. According to what Prof have already said, we don't really have enough data. So clearly, there are more women who were not captured in this WHO data in 2018. Now, from the patient perspective, what we have been doing is to see how we can really increase awareness for patient-to-lead advocacy on treatment and research. As I speak to you today, there is more priority given on communicable disease than even in non-communicable disease, especially in terms of funding. Many patients receive a lot of treatment, but the outcomes are usually very poor. These poor outcomes are not happening because these patients are not adhering to the treatment in many levels, but because some of these medicines were not really tested or were not field tested with these women in their community. What we've experienced, in Nigeria have been what we call helicopter research. People come, pick this data, do research, and then head off. So there is a need to really rethink global research. There is a need to rethink, global cancer research investment. As I speak to you today, in 2015, 2016, funding agencies collectively funded over 10,000 research organizations in over 174 countries. 3 countries of the US, the UK, and Canada accounted for nearly half of the grantees. That is over 5,000 grantees. And less than 10% of these grantees, that's roughly like 1,000 grantees, are located in Africa. And as we speak today, by 2040, the number of cancer death and mortality in Nigeria and many countries of Africa and low and middle income countries will definitely double. Do Nigeria and Africa have the research capacity to deal with this cancer crisis? In Africa today, we have less than 150 oncology trials in breast, cervical, lungs, and ovarian cancer happening. And most of these clinical trials actually only exist in countries like Algeria, Egypt, Kenya, and South Africa. Nigeria presently have only 6 clinical oncology trial going on. But this is actually a country that have the highest burden of cancer in Africa. So anytime I have conversations in issues like this, I'm usually told that in many countries in Africa, we don't have infrastructural capacity. But I think that global oncology investment is not just meant to just, do the research itself, but also to strengthen the infrastructural facilities.
Thank you. sorry to cut you off. I think we're slightly behind, so we're going to come back to that, because I think that just is also a very striking thing about where the, you know, the cancer burden in relation to the kind of cancer investment and the you know, the limited amount of investment. But just on that, and we will come back to that, Runcie, because it's very important. But Mary, if you have a wealth of hands-on experience with the Cervical Cancer Research Network, and specifically experience with efforts to increase access to clinical trials, and indeed, I would assume, get clinical trials off the ground in low and middle income countries. So could you say a little bit about the Cervical Cancer Clinical Trials Network and how it worked? And you know, it's from that, I guess, what lessons did you learn that you might share with us and impart in terms of what we might do in the ovarian cancer community?
Thank you, Clara, and thank you very much for inviting me to contribute today. I feel very sort of under-equipped in many respects, having listened to all of the wonderful speakers on before me. We sort of, back in 2012, the concept for a cervical cancer research network evolved. And it really evolved at a time when we had 2 publicly funded or academic clinical trials in cervical cancer that needed to recruit a couple of thousand patients. And we're very aware of the fact that cervical cancer is a huge burden in the low and middle income countries, and it's still a burden in the West, but and in other parts of the world in the high income countries, but less so, I guess, because there's more access to screening. So that really got a group of us thinking about how can we change this? How can we involve our colleagues? And I guess in the low and middle income countries, and I guess we were a tad naive in thinking that this might not be such a difficult task. But really what we found out along the way is that, you know, there are many different challenges to establishing clinical trials and to getting centres in low and middle income countries to participate in studies. And we have, you know, some of those issues have already been raised. One of them is, you know, a lack of infrastructure. And, you know, and infrastructure is just, it's so important to be able to actually get started on the clinical trials program. So do you have money? Do you have funding to set this up? So do you have somebody who can collect data? Do you have some dedicated space? Do the individuals have some time? And invariably, you know, there's no shortage of enthusiasm, but there's a huge shortage of time and resources. And then there are all the complexities about actually conducting clinical trials, not least of which, aside from the funding, is the issues of insurance and indemnification. It's working across national and international boundaries. It's data sharing. So there are lots of different issues that we were pretty well, many of us, I think, fairly ignorant of when we started on this journey. So to cut to the point, I mean, we've now got 27 sites in 14 different countries that are affiliated to the network, and we're continuing to grow the network. And what we initially wanted was we wanted sites to link up with us that actually had capacity to do clinical trials. But we've realized that there is more to research than just clinical trials, and you've hit on it already. Data collection is very important. So we've expanded the concept of the network, and we're encouraging more sites to join because research takes many forms. And we acknowledge and accept this, and we'd like to encourage that. So we have some very small grant initiatives that we're going to make available to CCRN member sites to actually undertake some research, primarily into cervical cancer, but it could be around data collection or audits. So that's just something to throw out there, and we'll be advertising that. Then just wanted to briefly touch on a couple of other issues. I mean, it's so important to have, as Sunda said at the beginning, it's so important to have participation from different geographical and cultural backgrounds in clinical trials, because ultimately we really want to be able to ensure that any results that we come up with, any findings that we make, any new treatments that we want to recommend, we need to know that they can be safely implemented across different healthcare settings. And this is really important when it comes to radiotherapy or chemotherapy. It's important as to whether those treatments will be acceptable to the population that where you need to use them. So we have encountered all of those, and I've personally, sort of had been obviously, or I'm aware of those issues with our clinical trials. We've got clinical trials running in Mexico. We have some sites in India that are CCRN sites now. We have sites in China and Russia, and there are all kinds of different issues and ethical issues that come up when we try to, sort of set up clinical trials. The trust issue is another one that somebody mentioned earlier, and the mistrust. And when we were on, we were holding one of our regional symposia in Eastern Europe and in Romania, where cervical cancer is a huge public health problem. They were very fortunate in that they had access to the HPV vaccine. And those, I mean, I think it was less than 5% of the population actually accepted the vaccine. And part of that was, this was an Eastern Bloc country, formerly, sort of under dictatorship rule. And so everything that came from the government was seen in the wrong light. So I think it's highlighted a very important point, and that was that they tried to implement a vaccination program without taking the population with them and without engaging adequately with the healthcare professionals. So I think this all comes back to communication and how we communicate with each other and getting our local champions to actually push the cause.
Thank you, Mary. That's excellent. And I really like your point about research takes many forms, that, we sort of are drawn to the clinical trial discussion, but actually the kind of back end is all around the epidemiology and actually creating perhaps a culture where engagement with research is actually seen as a positive thing. And that speaks to your point about trust. So I think we've covered a huge, it's been a really interesting kind of discussion around the challenges and the opportunities, and some of the key themes that have come out are really about communication and trust, and clearly a lot about infrastructure. So Renzi, I might come back to you because I worry I cut you off mid-sentence, and I think you've got such great insights, but I wanted to come back to you and sort of put some of the points that maybe Mary has just raised about, how you work with a community and what are the things that actually need to be in place in terms of relationships and involvement and stakeholders that would then lead to, for example, more funds. You highlight at the start inequality in terms of, or inequity in terms of funds that are, in the US and Canada and the UK versus countries where, the burden of ovarian cancer is particularly high.
Okay, thank you very much. I think one interesting issue that we have actually experienced, and most of the patients that I have worked with have also experienced, is in terms of diversity of the team. You see, this is really a very serious issue. Like when we talk about diversity, and diversity shouldn't just be about the diverse patient engaging in the clinical trial or engaging in the oncology research, but also the diversity of the team conducting those research. That is really, really important. And these are also a lot of issues that we've had in the past. So it's always very important to really think about ensuring that people doing the research themselves, also the team is really diverse in as much as we are bringing the diverse patients. And then for trust issue, what has really, really worked, I was part of a research that we did that involved about 1,000 patients in Nigeria here. And I realized one way to really sort out a trust issue is to engage people from the beginning. Sometimes in research, we really miss it that the patient or other stakeholders are engaged in the middle of the project or when the project is almost ready to shoot out. At those times, you definitely will miss out the very good opportunity to understand the cultural differences and how these people will perceive, this research or this oncology, research that is being done.
And I think that does, it's a simple concept, but it's about, the ownership of research and whether it's something we do to people or something that people are, you know, genuinely engaged with and involved in. Sudha, I know you want to come in. You have quite a bit of experience in Birmingham with multi-center studies, so that would be helpful to hear about that.
I hear what Ransi says very, very carefully about helicopter research. At Birmingham, we run the NIHR Global Surgery Unit. And we have a number of surgical trials running across the world, from South America, in many countries in Africa, in India, in the Philippines. And I myself am involved in CRANE, which is a trial of low-cost sustainable nutrition in people with cancer. So it's really looking, and it's open in Ghana, Malawi, the Philippines and India. So it is possible to run multi-center trials, and it is possible. And we've just finished COVID Surge Cancer, which is, we have 50,000 patients data collected from the COVID time, managed between March to 20 across the whole world, from 73 countries, including Sub-Saharan Africa and other low and middle income countries. So, I mean, certainly at Birmingham, we've worked on two principles. Firstly, that we're not interested in helicopter research. And I think I totally understand this business of people parachuting in, being senior authors, and then sort of people have to capacity build. So the ultimate aim has to be that people run their own trials. And so it's really important. We have a prioritization workshop run every year, which basically is a brainstorming exercise for surgeons to come up with their own ideas. And then we provide the methodological support to build them up. So I'd encourage people to look at the NIHR Global Surgery Unit website. It's called globalsurge.org, I think. And there's a lot of free educational materials on there on good clinical practice, on recruiting people into clinical trials. And we have actually succeeded across the world in huge big trials. You know, I'm talking about 5,000 people for an infection trial, 10,000 people for a trial. So it's not, you know, these are not cancer trials, but these are surgical trials, which arguably are harder to do. A lot of it is about will, a lot about which I'm afraid the global cancer community has had less of. A lot of it is about resource stratified care, which again, the local global oncology community has been a bit less interested in. For CRANE, for instance, we have MRC funding, and we were very, very clear that we would explore hospital generated nutritional products rather than sort of bought products. So products that were locally sustainable and locally sourced rather than commercial. I mean, we would explore commercial alternatives so long as they were sustainable in the local economy. And that's MRC funded. That's been going on for a few years' time. It's a pilot project, but that'll go on. But our other trials, Cheetah, Falcon, Penguin, they're all open and running now. So the issue is not that we cannot run trials across the world. The issue is not that we cannot run data collection projects across the world, because we have done both. The issue is, how do we do this in the cancer space? And again, we've done that as well this year with 50,000 patients being collected in COVID Surge Cancer. So I think the answers are, you have to work with people. You cannot helicopter. You must make sure that the ideas that come out locally are supported and developed methodologically. Funding is really important to support this. In India, for instance, National Cancer Grid of India runs very good workshops. They've got a workshop now called Credo, which is how to develop a research proposal and how to take this forward. I know a little bit more about India than I know about Africa, mainly because I'm from India, and therefore I've maintained links with India. So all of this is possible. The global oncology community needs to appreciate, A, that diversity matters and that diverse populations matter, that resource stratification in the treatments we provide is not is just as important as providing the most cutting edge care, and therefore trials with that are useful. And we need the same sort of resources that the NIHR and the World Health Organization have put into other spaces. For instance, I mean, yesterday's announcement on the cervical cancer 90-70-90, this has happened over 20 years of investment by the Gates Foundation and by the IARC and the number of trials that have been done in commercial and academic sectors. So it is possible. You know, I remember the first VIA trial. So it is possible. All of this is possible. It's deliverable. It's doable. We just need willpower and funding and the willingness for people to engage in and have communications.
Thank you.
Sorry, it's a long-winded.
No, that's okay. Actually, in some ways, I feel that you've really summed up a lot of the key points that, and you have summed up a lot of the key points that have come out. We have some comments. I'm going to sort of just do a little summary. You have sort of 5 minutes max left, and I'd like to give everyone a chance just to reflect and say a few words, literally 30 seconds, in terms of kind of takeaways and thoughts that maybe, you know, inspired as a result of this discussion. But a lot of our comments are really about, you know, going back to the basics, the importance of regional cancer data, understanding epidemiological data, understanding local populations, and maybe needing to start a holistic approach to the collection of data and understanding data and using it, including, you know, stem cell banks, etc. A lot of support for Runsi's comments about, you know, the trust and ensuring that, you know, concerns and comments about sharing data from the part of patients, and also comments around the significance of two-way communication and I would say engagement. So Tomi, if I could turn to you, do you have sort of just your last kind of thoughts and comments on what you've heard this morning and perhaps or this afternoon for you, and what you may be taking away?
Sure, I think you know, a lot of the initiatives and strategies that we've been discussing are actually not complicated. Is one of the takeaways. You know, things like building trust takes time and some effort, but it doesn't cost any money, and you know, it has such powerful impact on, you know, both patients' psychological well-being, adherence to treatment, participation in trials, and better outcomes. Thinking about access to care too doesn't, you know, appear to be related to building more hospitals or hiring more doctors. It's about reaching out to those communities that may be, you know, underserved in different ways, building trust, building diverse teams. Those are all pretty simple strategies, I think, that across cancer types and across countries, we can start to do immediately to improve cancer outcomes. And then layered on top of that, we can consider the BRCA testing, the clinical trials, infrastructure.
Thank you. Thank you. Brilliant. Rose, any last thoughts?
Well, it's just, I mean, the last speaker has just said it all. I mean, we were not asking for too much, but the basic things, I mean, we need to have good data, and then we need to know the epidemiology of this disease. And then from there, we can now move into the biology, the genetics of, you know, and, you know, but I think getting data and then the epidemiology are quite, you know, easy to do. We can do that, if, you know, I mean, with collaboration from other people, other centers in Nigeria or other centers across Africa, we'll be able to get that and present. So I think that's what my main comment there. From that stage, you can now move to the next stage, high-powered research.
Thank you. And Runsi, last thoughts?
Can you hear me?
Yes, we can.
Okay, thank you. Yeah, so my last thought is just that, you know, apart from the patient trust, another dimension of trust that needs to be addressed is trusting the local researchers. Very important. Another last thought is, without sufficient and actionable oncology research with African and across the world, you know, Black people and other people from other races will continue to die from ovarian cancer. Thank you so much.
Very powerful kind of final thoughts. Mary, anything you'd like to share?
Yeah, I think I agree with everything that's been said. And I think supporting our colleagues in low and middle income countries to actually address the issues that are most pressing to them, and understanding that the issues that are most important in their communities may not align directly with the questions and the research questions that we're asking. So I think more cooperation and discussion, and I think this came out already, more involvement of a wider group of people from more diverse communities in designing the clinical trials in the first place. And I think the other point I'd just like to make is that, cooperation between groups is just so important. If we just think about what has been achieved with COVID, in that we've gone from a disease that was unknown and unheard of at the beginning of the year for most of us, to a trial concept, recruitment, and data analysis, all in less than 8 months, ready almost to deliver a treatment. And I think this is a very powerful way of showing that if we cooperate at all levels, from regulatory through to national and international researchers, healthcare professionals, and engage with our communities, anything is possible.
Thank you, Mary. That's really helpful and interesting. Just as you were saying this, a comment popped up from a participant from Canada talking about how the COVID-19 has actually enabled them to kind of overcome some of the obstacles that would have been there in terms of participation in trials. So we're at the end of our session. I wanted to firstly thank everyone, all our panel members. You have been truly outstanding, and it's a great honor to be in your company, truthfully. And obviously all of our delegates that attended today. I hope you enjoyed it as much as we did, and thank you for your comments. We will pull them together. And our final kind of, I guess, slide or point is we want to share a save a date with you. We have another event happening that's related to our charter that's in the new year. So January 28th and 29th, we'll be talking about the importance and value of information and support for those living with ovarian cancer. So again, thank you all. You've been just an outstanding group of people to share a morning over coffee with, and I wish you all a really productive day, and hope to talk to you all soon. So thank you so much, everyone.